What are the indications for cochlear implants? And so what I like to do is just talk about a couple of key pieces of information that I really think you're going to be asked about in your office. And one of them is when you just look at the projections of hearing loss, and this is a study that was published in 2005. And I think what we've noticed is that it's actually more of an asymptotic curve with a number of people with treatable hearing loss projected out to 2050. And it's a staggering number. And what's really interesting is right about 2014, the data came out linking the early onset of dementia to the level of hearing loss. And this is a summary of a lot of papers that have come out. It was the work that was first exposed by Frank Lin from Johns Hopkins. And he looked at several databases. He looked at the Baltimore Center of Aging database. He looked at the Framingham study. In the Framingham study, going all the way back into the 70s, studying cholesterol for heart disease was the design. And George Gates, who was at Washington for a while, was on the committee, and George was the consummate bureaucrat. And he was sitting there and very casually said, why don't we do an audiogram on everybody, just a pure tone audiogram. So just looking at pure tone audiograms, not discrim or anything else, this data has been produced now following people up to 45 years. And what you can see is if you have a mild hearing loss on the audiogram, you have roughly a 2 times relative risk of having an earlier onset of dementia. When you have a moderate loss, it's 3 times. And when you have a severe loss, it's 5 times the relative risk, okay? And the confidence intervals are very tight. This is just epidemiologic data. This is just data that's derived from pure tone audiograms. So the way I frame this to patients, and what you'll see here is some patients are now Googling dementia and hearing loss, and they're coming in pretty interested to find out what they can do about it. So what I always tell them is that there's plenty of people with dementia that have normal hearing. And there's certainly plenty of people with hearing loss that don't have dementia. And the theory behind dementia is it's a higher order reprocessing. So you are diverting more of your energy, more of your neuronal energy into fundamental hearing than you are higher level reasoning. In this situation. And the question is, and there's good functional MRI data to support this, and the question is, if you intervene with a hearing aid, with a cochlear implant, can you reverse a person's relative risk? And the NIH, which is funding at about the 7th percentile right now, last time I checked, came to Frank Lin and gave him $25 million over 5 years and said, could you do a study seeing if we're seeing reversal in the trends? Does intervention actually reduce the risk of meningitis? And the early data coming out of that, just from some presentations I've heard and abstracts I've read, are very encouraging. And so this alone may drive Medicare to hearing aid coverage. It is certainly going to drive down the prices of hearing aids. And now you're seeing over-the-counter hearing devices will probably be available at the Walmart closest to you very soon, right next to the glasses you can buy for $20. So you're going to get a lot of questions about this. I am now in private practice. I have an audiology department, and we're not fighting this. We're actually selling these devices, and we're encouraging people to follow through on their technology so that if that doesn't work for them, we get them into a hearing aid. Okay, so this is extremely important. I was invited to Japan, and I spoke to the Japanese health minister on behalf of the Cochlear Corporation about 4 years ago, because in Japan, that era of Japanese just don't die. They live to be about 95 to 100, and they're very physically healthy. They've treated cancer, they've treated heart disease, and now they're seeing people getting an extraordinary amount of dementia popping up, and it's costing their country a huge amount of money in their national health system. So this is going to become a national health issue, but you may get some questions about it. What I tell patients is Google it, Google hearing loss and dementia, and go to the NIH website, because that's the best data that you're going to be able to read. It's a good synopsis. What are the components of hearing that are so important, particularly when talking about a single-sided deafness? Well, if you have 2 ears, you never lose half the signal. The way we actually localize sound is by sound hitting our ears at different times. And the discrimination of timing is in milliseconds. And if you lose it on one side, you have what you call the head shadow effect, so you're missing that information. But the other things that you lose is when you have two ears, there's redundancy in the signal. There's also noise that gets canceled out at the brainstem level to give you something called binaural summation. And it's a very complicated audiology term that when you ask a surgeon to explain, it means 1 + 1 = 4. It gives you much more clear hearing, better speech discrimination, and is possible when you're getting stimulus from both sides coming into the brainstem. The squelch effect is actually your brainstem mixing speech and noise that it's getting from one ear in comparison to the other. So your whole auditory system, just like your balance system, is about comparing one side to the other. And so the squelch effect is really only possible if you have hearing from both sides. So if you use something like an osseointegrated device, a Baha, a Ponto, that will overcome the head shadow effect. Binaural summation plus minus, squelch effect doesn't happen. Localization, not really, okay? If you use a Backous hearing aid system, it's actually much better at localizing sound. It doesn't give you squelch effect, doesn't give you binaural summation, but it gives you sound from both sides, and you actually program in the audiology or the actual circuit itself programs the intraoral difference so that you can actually localize sound much better. A cochlear implant is the only device that you can put in the inner ear to stimulate the auditory nerve on that side. And there's no question that head shadow effect is removed. There's no question that you are getting localization at a much higher level than you would with deafness or a Baha. The other factors are still under study. So what are market indications? Well, moderate to severe hearing loss, now profound hearing loss, is really in the cochlear implant territory. And so I was asked earlier, I think Dean asked me, how do you know if a senior citizen should be evaluated for a cochlear implant? And the definition is if they're properly fitted with a hearing aid and they're struggling, they should be evaluated. Because the speech discrimination scores that we use for candidacy are pretty much becoming standard across the country. It's an AZ Bio list. What's not standard is a signal-to-noise ratio that we apply. So some of your patients may have 65, 70% discrimination on the routine discrimination testing you're doing, but their hearing aids are not doing it. And so we evaluate them. We put them in a signal-to-noise ratio of about +5, and they crash. And they become cochlear implant candidates. And those people tend to do better with a cochlear implant than they would with a hearing aid. And keep in mind, they're coming to you because they're not doing well with their hearing aid. There's an additional test that we do pre-op, which is the CNC word tests. Very difficult word test for people to do. And depending on where you fall on that CNC word testing, that will predict your outcome with the cochlear implant. So will we exclude somebody from a cochlear implant if their CNC words are too good? No, but it's a totally different conversation about what you can expect from the cochlear implant if those words are better. So it's about expectation. But we are now, the MED-EL Corporation went to the FDA and got approval for single-sided deafness for cochlear implants. So again, approval does not mean payment. And the FDA approved MED-EL's request, but that applies to any cochlear implant. They're not going to say only MED-EL is approved by the FDA. So we're still giving people a choice of implant, but even in single-sided deafness now, we're really seeing good tinnitus control and much better performance than even with hearing aids. The ossiculoplasty sometimes can be used. There'll be times when we'll correct a 40 dB conductive component in a mix loss in someone that's got a sensorineural level of 40 to 50 decibels. What we do is we take them from not able to use a hearing aid up to a level where their ossiculoplasty allows them to use a hearing aid. And when you get to about 30 to 40 decibels of conductive hearing loss, it makes hearing aid use extremely difficult because the hearing aid has to separate the microphone and the amplifier. And as you turn it up, it starts hearing itself and giving you feedback. So sometimes we'll do that. The osseointegrated devices are very effective. Baha is very effective. Ponto is very effective. MED-EL has the sound bridge, the vibrant sound bridge you're going to hear a lot about. Cochlear now has the Ossea, and that's a totally under the skin, no percutaneous device. You clip a magnet on it, and it looks like a cochlear implant, and it gives way more power, much more fidelity. The problem is the companies have placed the pricing on the products higher than the total reimbursement for the procedure. And so they're going to have to come around and lower their prices. And I think what they're hoping for is a new CPT code, so they crank their prices up. The problem is they don't understand CPT coding very well. And this has been taken on at the level of the academy. I'm on the board of the academy, and the academy will never take a position that's going to devalue a CPT code and work against the physicians in the academy. So this is yet to be worked out. You'll hear more and more about these, particularly since Cochlear is diverting about 70% of their advertising to the Ossea now. So we'll see how that comes out. Single-sided deafness, again, you can get a cross hearing aid system. And, most of our patients, we have them try that. People who are much more adaptive to a hearing aid system are those that have hearing loss in their better ear. So bi-cross systems, we have pretty good buy-in from patients. The people who have just one side that's bad and one side that's normal aren't psyched to put hearing aids in both ears, or as they've told me, hearing aid-looking things in both ears. Cochlear implants, as we talked about, the Osseointegrated devices from Baha Connect all the way to Ossea. And you can see all these products out in the waiting area or out in our display area. NF2 used to just be either you were deaf and signed or you got an ABI, auditory brainstem implant. An auditory brainstem implant does not give anywhere near the hearing of a cochlear implant. It's usually the equivalent of about a single channel cochlear implant, and it's really variable. What's interesting is we're now putting cochlear implants in people after surgery for acoustic neuroma. We're putting cochlear implants in people who have acoustic neuromas and still stimulating them well, and they're getting much better hearing. So oftentimes we'll do a CyberKnife or a Gamma knife, insert a cochlear implant, and they end up hearing quite well out of that cochlear implant side. So the expansion of cochlear implants is huge. So when it comes back to really what are the keys to referring a patient for a cochlear implant, if you are thinking in your mind they should consider a cochlear implant, refer them. And that's what I would tell you, because if nothing else, we're going to present to them a series of hearing options, and if you offer them in your office, we're going to send them back to your office to get it. We're not out to swipe anybody's hearing aids, but there's so much available. The other powerful one is tinnitus with cochlear implants. There's a good study out of the Netherlands showing significant tinnitus suppression, particularly in people with single-sided deafness. So if you have the combination of single-sided deafness and tinnitus, or single-sided deafness and hearing decrement in the other ear, I'm 100% getting those people approved for cochlear implant. Medicare is different because they don't approve. They just take all your money back and then audit you. And it's usually about a $3 million process. So we're very careful with the Medicare patients. The other thing I'll add to this is balance in hearing aids and balance in cochlear implants. There's a growing body of information that people who get a cochlear implant or two cochlear implants see significant balance improvement. We're also seeing it in patients with hearing aids. And it makes sense. I mean, you're stimulating the same labyrinth, but you're also giving them the ability to use other senses to compensate for their balance. In our panel, we'll have a little later, Morgan Chris is here from our balance group to talk about that. We put hearing aids on little babies. We put hearing aids in old people like me. This was kind of the Black Angus stainless steel dance floor picture from the 70s about hearing aids. I just love it. Hearing aids are now extremely small. It looks like you've got fishing line going into your ear. And I'll have patients tell me, like, look, I'm not ready to be old yet. I'm extraordinarily good looking. And I said, and you look really stupid when you keep having people repeat themselves. So beauty is a sphere of influence that includes your ability to communicate. So I tell them, get a hearing aid and try it. I only show this slide because it's the coolest slide ever invented, because it has little red things that click across the left side of the screen. But what ends up happening in a Baha is it stimulates the cochlea and the foot plate directly in an ear with a conductive loss, bypasses the entire middle ear and mastoid system. In single-sided deafness, it crosses over the vertex of the skull and stimulates the opposite side. So in someone who's got a conductive loss and normal hearing on the other side, it will actually stimulate both ears, but you're not picking up that stimulus if your ear hears well on the other side. You've seen the development of I guess this isn't working. On the left side, you see the fixture from Cochlear that has no hydroxyapatite, and the one that's sprayed with hydroxyapatite. So those are designed to reduce skin infections. Med-El has the bone bridge. Medtronic used to have the Symphono, which is a very similar device to a sound bridge. They've stopped marketing that in the United States. And the Vibrant Sound Bridge from Med-El is no longer marketed in the United States. So they've dropped off. simply because nobody could pay for it. If you look at Baha, there's folders out there that you can pick up talking about which Baha to use depending on the level of hearing loss. But what's really incredible is we have people with severe mixed hearing loss that we put a Baha power on. And I'll tell you, when they're on, you can almost see their molars vibrating, and they hear very well with it. So these devices really do provide a lot of recovery. So we've had people all the way down here that we've tried them on, and they have responded quite nicely. These are also people now in a mixed loss that you consider putting a cochlear implant in. So I think the indications are really a moving target. This is the old Baha surgery where we made an incision. It's now been reduced to a 5mm skin punch, a drill, a countersink, and it goes in with a torque-driven drill system. It takes about 6 or 7 minutes for Professor Bartendale to do a Baha or a Ponto. So it's not a big operation for people. We would do this in the office, but the only way to get paid is if it's in a surgery center or in a hospital operating room. That's just the way the FDA or the CDC is paying for it. This is Baha Attract. This is actually a magnet under the skin with nothing that goes through the skin. And this is really falling away in popularity with the onset of the Ossea device. The problem with the Ossea device is if you have somebody who requires frequent MRIs, like a tumor patient or MS patient, if you put a magnet on their scalp, you've got to take it out every time they get an MRI. If you put an Ossea in, you're going to have artifact. You put a sound bridge in, you're going to have an artifact. But the cochlear implants and these implantable devices now have magnets that align in parallel to the magnetic field of the MRI scanner and cut down on the imaging issues and certainly improve the safety. So people with cochlear implants are getting MRIs now, but the MRIs aren't perfect. On the left of your screen, you see the Ossea device from Cochlear. On the right, you see the Vibrant Sound Bridge. These two are available currently in the United States. Anybody can get one, they just have to pay for it. So cochlear implants, you're seeing lots of new developments in the companies. Advanced Bionics, MED-EL, and Cochlear are the 3 players in the US. Oticon Medical, enormous hearing aid company, has just bought a hearing aid company, or excuse me, a cochlear implant company in France, and they'll be coming on the US market presumably in the next year or two. There's a lot of issues about power utilization versus electrode placement, and the bottom line is we're now able to put cochlear implants in and preserve the residual hearing on that ear. And that's important because if you preserve low-frequency hearing, you can get high-frequency stimulation with the implant and low-frequency stimulation with the hearing aid on the same ear, and their performance is much more close to natural hearing. So it's a pretty amazing developments. This, by the way, going back, this is the magnet package, which actually rotates in the magnetic field in the patient when the MRI scanner comes on, and reduces heat, reduces movement, and reduces the amount of artifact that the cochlear implant is sending across the MRI. So even in NF2 patients now, we put these in, we position them differently so that we project where the image artifact would be, so we try to exclude that in our field. And just a couple of quick studies. This is just looking at single-sided deafness and cochlear implantation. This is Doug Sladen, who was at Mayo Clinic and is now at Western Washington University, did a nationwide study. It really showed that the single-sided deafness patients did better in their hearing. You look at the study by Kurtz and Mueller, and it really, the protocol is challenging. You've got to be very specific in the patients that you implant. And you can see the body of literature is growing, and this is what we talk to insurance companies about. But this is being done very judiciously. We're not just slamming cochlear implants and everybody with a single-sided deafness, because we want to try to pick out the people that we project will do better with it. Tinnitus, basically the cochlear implant is stimulating the auditory nerve. Nobody knows quite why it's happening, but the tinnitus is suppressing. If they shut their device off, and most of those patients, it came back after about 30 days. So they really need to keep it in there. Just a couple of cases. This is a young child with a conductive hearing loss. You can explore this child and do an ossiculoplasty. I would recommend a CT scan on all these kids, particularly if they have any form of atresia. You'll never get hearing like you're going to get with a Baha. And so what the audiologist will do is put a headband on them, because they need to have a skull thickness of at least 3 to 4 millimeters before you can implant them. And they'll wear that headband when they're in class, and they actually hear quite well. And over time, they'll adapt to the Baha, and then when you put it in, they'll do great. And when they buy the Baha device, it's actually around the cost of a hearing aid, so it works really well. I will do middle ear exploration on a young child. If they have stay-piece fixation, I have a deal with the parents that we're going to stop, let the child get a little older, so that we can control their post-operative behavior a little bit. And I'll do a stapedotomy on a child, 9, 10 years old, if they're a kid that's controllable. If it was me and the way I was when I was 9, I would have got my stapedotomy at 17. So this is a gentleman comes in, and part of this is you see a bald guy, and I take that very seriously, with the cochlear implant. It just isn't that big a distraction for people. And what you're seeing is this is somebody who could get a Baha, could get a Ponto, one of the osseointegrated devices that's percutaneous. He also is kind of on the fringe of being able to use a hearing aid. So we would try him on a hearing aid first, and then go and consider putting one of these devices on him. As you're getting more and more severe, these are the people sometimes you'll do an ossiculoplasty to bring them up to a level where they could use a hearing aid better. The problem is you get into what we call a masking dilemma. When you're applying so much masking noise on the side you're not testing that it crosses over, and the patient can't determine that it's a crossover. So some of these people we operate on, some of them you can put a high-power Baha on them. Some of them, their discrimination is so poor, they end up getting a cochlear implant. So again, not doing well with hearing aids, confusing audiogram, refer them, we'll sort them out. Case number 4, this guy was always a Baha or a Ponto patient. Now this could be a very good cochlear implant patient. And you got to pay attention to the right ear and that high frequency sensory loss. So these people get an annual audiogram, and they get a free ticket in a clinic anytime they feel a drop in their hearing. And again, this is a lady that had 2 stapedotomies done and ended up getting a Baha and was quite satisfied. This was her hearing level. She ended up having a penetrance of otosclerosis, which affected her sensorineural hearing as well. And if you look down at her CT scan, she's got a halo sign. So she's an advanced otosclerotic. These are the people that I would put on fluoride and keep an eye on them. But she's doing very well with her Baha. So we wouldn't really do much else. If she were to drop her hearing and we put a cochlear implant in, we would be concerned about facial nerve stimulation. Because the facial nerve comes right here. Jacob ganglion is right next to the basal terminal of the cochlea. So very, very important. So in conclusion, there is a lot going on in the osseointegrated world. The Ossia is going to be a very promising device. We hope to be able to be putting that in soon. The Baha right now is a very effective device. We have a very active Baha program. I love when people around the country say, my patients don't want to look like Frankenstein. I've never heard that in my clinic. If you explain to them that they can hear better and you show them the device, most people accept it pretty well. I think we're seeing a cross between how do we use hearing aids, how do we use ossiculoplasty, how do we use these osseointegrated devices, particularly in people that have had multiple ear surgeries for chronic ear surgery, or cholesteatomas, chronic otitis media. Should these osseointegrated devices be first-line treatment of those people instead of last-line treatment? So there's actually an international consensus group that's meeting once a year in Europe looking at this. And I've got the privilege of serving on that. It's a really interesting group of people. And cochlear implants and single-sided deafness is here. Tinnitus suppression is something we don't promise, but typically we see at least some level of tinnitus suppression. And certainly in our patient population, we've seen balance improvement. What we have not seen a lot of is people getting balance problems from getting a cochlear implant. That just has not panned out. And the electrodes are getting very thin, very much designed for restoration of hearing. So with that, I'll take you out to my beach house. This is where my brain goes when we have pandemics. And I just think it's a super place out on Hood Canal. You're all welcome to come.